Prem Soman, Mike Gibson, and we're talking to you live from ACC 2026, and you're talking about Acoramidis and long-term survival in people with amyloid cardiomyopathy. Talk to us about what you found, Prem.
Hello, Michael. Thank you for having me. Now, we now know that transthyretin cardiomyopathy is a prevalent disease, and it has a significant mortality and morbidity associated with it. One class of therapy that has proved efficacious are stabilizers. And Acoramidis is a very powerful stabilizer of the TTR molecule. The ATTRibute cardiomyopathy trial, which was a randomized trial of the efficacy of Acoramidis, showed a substantial mortality and hospitalization benefit in patients with TTR cardiomyopathy. What I'm presenting is the open-label extension data from the randomized ATTRibute-CM trial. Now, the 42-month read of the OLE was presented at AHA last year and showed a benefit of early Acoramidis and continuous Acoramidis compared to patients in the randomized trial who originally got placebo and then were converted to Acoramidis, showed a benefit of continuous Acoramidis therapy in terms of all-cause mortality and cardiovascular mortality. This abstract reports the 54-month data, and it shows that patients who had early and continued Acoramidis have a sustained and almost incremental benefit, showing a 45% relative risk reduction in all-cause mortality and a 49% risk reduction in cardiovascular mortality, showing no heterogeneity of effect across multiple key subgroups, and showing excellent tolerability and no safety issues. So very powerful data underscoring the importance of diagnosing ATTR cardiomyopathy early and treating it early.
Let me ask you this. Did the curves diverge and continue to diverge even more late, or did they just kind of remain parallel late?
No, they actually continue to diverge. That's why we have, for example, in the 42-month data, the hazard was 36%, the relative risk reduction was 36%. And at 54 months for all-cause mortality, we see a 45% risk reduction. And the curves actually diverge quite early at month 3 in the randomized trial.
Now here, people don't often realize it's great to have a bigger relative risk reduction. Usually the relative risk reduction goes down if the curves are parallel, but here it went up, meaning your absolute risk reduction got even bigger. What kind of absolute risk reduction in mortality are we talking about here?
So I think that's a little difficult to address from the open label extension phase because this is now no longer a randomized phase. I think the absolute risk reduction and the true effect of drug on mortality is actually gleaned from the randomized phase of the trial. And I think when you come to the open label extension, the most scientifically appropriate interpretation would be that you continue to get a benefit and that the people who were started on tafamidis late, started on Acoramidis late, don't quite catch up ever. And so the important
so there's a legacy effect of that early treatment that keeps giving.
That's true.
Yeah. And remind me, what was the mortality benefit earlier?
So that was the primary analysis was done as a hierarchical Finkelstein-Schoenfeld analysis with a combined win ratio benefit for the combined effect of all-cause mortality and cardiovascular hospitalizations of 1.8. And when analyzed by the traditional proportional hazards method, I think it was a 23% reduction in all-cause mortality and a 29% reduction in cardiovascular mortality. This is the original trial.
Got it. Right. Well, it's good to see that there's this legacy effects, that early initiation is the gift that keeps giving. You continue to accrue benefit, maybe even more benefit with early initiation as you follow someone longer. It's hard to catch up once you've had disease progression. Thanks so much for joining us today.
Thank you for having me.